Machlatzi. Hi, Dr. Pune.
Hey, Nicola.
How's
Hi,
it?
Dr.
Good
Anna.
afternoon, morning, good afternoon, everyone.
Would you like to test your slides?
Let me see.
Um, sure. So, Nicola, we wanted to ask, Dr. Penna has asked me to add her slides into my presentation,
Okay.
such that she can also, when the time comes, adjust the slides on her side. Is that possible?
Yeah, sure.
All right, sure. Let me share my slides. Just give me a second. How's the weather in Cape Town?
Sunny day today. It was cold over the weekend, but today looks promising for spring.
Okay. Yeah. Screen share. How's it looking?
Yeah, it's looking good. Do you want to
Right.
see if it advances? There we go.
Okay.
Perfect.
And in terms of pointer use, Nicole?
Um, so what Machlatzi can do is you can give slide control to Dr. Pune. I just want
Okay.
to remind myself how to do that. So, Machlatzi, the toolbar at the bottom of your screen, third from the right, there should be an icon that looks like a screen and it should say slide control underneath it.
So, hi,
Two.
Nicola and Mishlatzi.
Hi,
Hi,
Dr.
Charlene, how are you?
Fine, how are you?
Good, thanks.
Um, and hello. Sorry, is Dr. Perna? How do you pronounce your name?
It's Dr. Perna. Perna.
Perna. Okay.
Mm-hmm.
And are you a doctor or prof?
I'm a doctor.
Doctor. Okay. Let me
Yes.
I
let
promoted
me
you
show
by
you my
accident.
face. Um, I just want to say hello and nice to meet you.
And you. Thanks, Dr. Persna.
Let's see, can I send you? Yeah,
Sure. Can I ask you to maybe take a picture of the toolbar?
great minds think alike. I was about to. Cool.
Yeah.
I'll send it to you on WhatsApp now.
Yeah.
Host tools. Is that what it says? Host tools.
I don't think you'll be able to see it unless you're sharing slides. It should only show for Flatzy.
Okay.
Share. Okay, where is this? Because I am on the presenter mode now. Perhaps I need to leave that. Let's see. Okay, video. Okay, so So, Nicola, for me, on my toolbar, after annotate, there is a remote control. There is no slide control.
Okay. If you click on that, it'll give you a list of people, and then you just click on Dr. Perna.
Okay. Allow Zoom workplace to control the screen.
Dr. Perna, I'm just inquiring, are you how are we doing this? Is Mashlati, are you going to talk and Dr. Perna, and then are you going to continue afterwards, or it's you first and Dr. Perna, and then we end at that point?
No, no. I'm inserting the histopathology in the appropriate
Okay.
space. Dr.
So
Mangeli is
so
going
you
to
are going to be
continue.
popping in at a certain
That's
point
right.
of the talk, and Mashlati will continue. Okay. Got it. Thank you.
That's right.
So, Dr. Perna, it's saying it's awaiting for your response or something, but I think you
I
should
don't
be.
see I don't see an invitation to respond. You can control. Okay, all right, let's see. Okay. But I don't want to do any of that. Now it's giving me a screen that I feel you still controlling it. I'm not controlling it.
Is it?
Yeah. Let me see if I can advance. No, I can't advance.
Okay. Let me try settings again. So remote controlled. Dr. Perna is selected. So let me just show Nicola what's coming outside.
Dr. Perna, are you wanting to annotate on the slides, like write and point things out, or?
Yeah, to point out, not so much right, but to point out, yes.
Okay. Mahlati, maybe what would be easier then is if you keep control of the slides and then
Okay.
click through when Dr. Perna is ready to go to the next one, and then we can use the annotate feature for Dr. Perna from her side to point things out.
Okay. Does that sound fine, Dr. Perna?
It does. I just don't know how to do that. Shall I click stop participants sharing? Or should I just leave it as is? So, because it says here controlling Mashlatsi's presentation, but I'm not.
If you leave it as it is, at the bottom of your screen, does it have an option for annotate in the
Mm-mm,
tool? Nothing, right?
mm-mm.
And
Yeah.
and host tools, perhaps?
No, nothing. I've got nothing at the bottom that is visible any longer.
Okay.
Just to say, the cursor is moving, and I'm not moving it, Dr. Perna.
Can you see my
And
arrow? Am I
Yes,
moving
you
it?
can.
yeah,
I
Okay,
think
all right.
if you press on the screen, if you click, it should advance, but your keyboard arrows shouldn't advance it. There.
so there we go. It's
Okay, so it
advanced.
has advanced.
Yeah.
Can you advance as well, Mahlatsi?
Let me
He
see.
can at the same time as you, but well, he can, but not at the same time. Otherwise, he'll be fighting you for the cursor.
All right. Okay, well, that
Yeah,
works well. That's what we want. We want Mahlatsi to do it for the first 43 slides, and I'll pick up from 44 for about
Okay,
12 slides, and then, yeah, that works well. Okay, thanks.
good stuff. Charlene, would you like to? You're comfortable sharing the slides here for intro?
Yeah, so can I start sharing now?
Yeah, you can. I've made it so multiple participants can share. So Mhlatsi, you can leave
Okay.
yours as is.
Okay, sure. Thank you.
Perfect. Looking good. Good stuff. Working.
I just still see Mahlatse's first slide. I don't see anything different.
So at the top of the screen, there'll be tabs, the same as in a web browser. And then one says Mhlatsi screen, and the furthest right for me says Charlene Prasnath's screen.
Right. So one can toggle between those. Oh, okay.
Exactly,
All
yeah.
right. Okay, super. So what I see is not necessarily what everyone else sees. Is that right?
Correct, yes.
Okay. So once Charlene's done her introduction, then I'll just flick it back over onto Mahlatsi's screen.
Correct.
Okay, thanks.
Nicola, will you tell me when to start? Because I'm not seeing the number of participants. I don't know.
Oh, sure.
You, yeah,
We're
okay.
49 at the moment, so I think you can go
Okay.
ahead.
All right. Good afternoon, everybody. Nicola, can you hear me?
Yes, we can hear you.
Okay. So good afternoon, colleagues, and welcome to this afternoon's deep dive session. It's brought to you by Blood SA and Wits University today. And so today we have two wonderful speakers. And so Dr. Mhlatsi Mankele will be covering, well, giving us the findings of his 10-year retrospective study on extranodal NKT cell lymphoma. And so before we continue, I'd like to thank the Deep Dive Management team for putting together our Monday morning sessions. A lot of work goes into organizing this, so we are extremely grateful to the team, who is led by Professor Stal Verberg. Dr. Hardine Kritzinger is the National Training Coordinator, and Dr. Nicola Smith, she's a National Outreach Officer. Some housekeeping notes. So all these sessions are recorded and can be found on the Blood SA website under Resources Deep Dive. This is an interactive session, so please feel free to add any questions or comments in the chat box during the meeting, and we will respond to them at the end of the presentation, and or if need be, we could answer questions should they be relevant at the time. CPD points will be submitted to the HPCSA for all registered South African attendees. So please ensure that you're attending with your own registered Zoom link and not in a group. And you should attend for at least 1 hour. Please ensure that your HPCSA number is entered correctly when you sign up for Deep Dive. If you are not on the mailing list, please, you can join via the website, and or you could use the QR code which you see on the right-hand side of the screen. At the end of the talk, there will be a survey, which we would appreciate if you could complete, because it gives the team and the speakers some insight into what the audience feels about the presentation and how we can improve further sessions. Just a reminder that the Haematology Oncology Conference, the 17th one at least, is going to be taking place on the 19th to 21st of September at Century City in Cape Town. It's called Bridging the Gap, and we'd love to see everybody there. There will also be HHT session, and this is happening on the 19th of September at the conference center. So there's a few experts that have coming specifically to talk to us and about HHT. So please, for those that are attending the conference, to try and attend this as well. So today's agenda is basically a three centers data, which Mashlatsi has done his M4 on. So it's entitled a multi-center 10-year retrospective review of the frequency and characteristics of extranodal NKT cell lymphoma. And Dr. Hana will be giving us the laboratory perspective. So for those of you that do not know Mashlatsi, he's an extremely pleasant and polite gentleman. And I was really, it was a pleasure working with him during this study of his, because we also provided some of our data from our center. So Mashlatsi was really, really diligent. Despite being ill towards the end of last year, he still persevered and did really well on this project. So Mashlatsi, congratulations on doing so well. I'm really proud of you. So Mashlatsi is a hematology fellow at the University of Witwatersrand. He completed his undergraduate medical training at WITS in 2015 and then went on to specialize in internal medicine, and he qualified as a physician in 2022. His clinical interests span malignant and benign hematology, with a growing focus on improving access to high-quality hematology care in South Africa. Beyond medicine, Mashlatsi is an enthusiastic traveler who enjoys exploring new cultures and places. Our next speaker after, Dr. Yvonne Pana will be sort of interjecting in Mashlatsi's talk, because she'll be describing some of the pathological entities that Mashlatsi has in his study. So Dr. Yvonne Pana is an anatomical pathologist at the University of Witwatersrand and the NHLS in Johannesburg. She holds an MBCHB from WITS and a fellowship in anatomical pathology, combining clinical service with teaching and training of anatomical pathology registrars. Her research focuses on pathology of HIV-associated cancers, particularly lymphomas. She has co-authored several studies on lymphoma trends in the era of antiretroviral therapy, high-risk subgroups of HIV-associated Hodgkin lymphoma, and aggressive entities such as plasmablastic and diffuse large B-cell lymphoma, providing key insights into their clinical and molecular features in the South African context. So with that, I will hand over to Mashlatsi to present his research. Over to you, Mashlatsi.
Good afternoon, everyone. Can you guys hear me? Sure. Okay. Good afternoon, everyone. Thank you, Dr. Parasnath, for that rather charming introduction. Thank you, Vladese, for hosting us today, and thank you, Dr. Pena, for presenting with me today. Okay, I will be presenting data of a small project I embarked on, and yeah, I hope you enjoy the talk. So my project was basically a multi-center 10-year retrospective review of the incidence and characteristics of extranodal natural killer T-cell lymphoma. And as I've been introduced already, those that don't know me, I am a fellow in clinical hematology at Chris Hani, also a specialist physician. In terms of declarations, I do not have anything there. And then just a disclaimer that this is unpublished data. It's a work in progress. We hope to publish the data sometime, hopefully soon. Okay, this is the content of my talk. Basically, we'll start off with a case. I'll go through the background of extranodal natural killer T-cell lymphoma, and then we'll delve into our study and share those findings. Okay, so let's kick off the show with a case. This is a case from Chris Baragwana. Basically, it's a young man that was 31 years old. He resided in a township in the south of Johannesburg, South Africa. He was negative for HIV, and he was not known with any other comorbidities. He presented to a healthcare facility with a 1-week duration history of bilateral nasal congestion and a 6-month history of a headache, where he was assessed as having sinusitis. He was treated with a course of antibiotics and antihistamines. He had no improvement on his treatments, and over the next 6 weeks, his face swelled on the right, and he developed bilateral purulent nasal discharge and a loss of vision on his right eye. He had B symptoms in the form of loss of weight, as well as drenching night sweats. In light of his non-resolving symptoms, he was ultimately referred to the ENT department here at Chris Baragwana. On examination, the patient had no peripheral lymphadenopathy. He had no abdominal masses or hepatosplenomegaly. What he did have, though, is an ulcerated and necrotic lesion on his right inner cheek, and this was complicated by cellulitis of his right face. The Waldering lymph nodes were not enlarged. These are pictures of him that I asked for permission to share. The point I took history from him, and what the pictures clearly demonstrate is cellulitis on the right side of his face. And at that point in time, he was already blind in the right eye. You can't appreciate this in the pictures, but yeah, his right eye could no longer follow movements, basically. As well in the picture is the inner right cheek. And what you can appreciate there is that ulcerating necrotic lesion that he had there. He was obviously then started with a workup. The first workup was basic bloods. What you can appreciate there is the FBC, which is already showing bicytopenia. Unfortunately, a diff count was not done at the time. There was a UNE that showed a hyponatremia of 129. His liver function tests were very deranged. He had an elevated LDH of 971, and his beta-2 microglobulin was elevated at 6.8. Further of his workup, he had a CRP of 84. He had a coagulopathy with an INR of 1.24. He presented basically during the peak of COVID, and at the time, COVID swab was done on him, which was negative. Multiple blood cultures were done on him that were negative. He had a beta-D glucan that was negative. A nasal swab was done to look for TB that was negative. A nasal swab was also done and sent for culture, and it was positive for Klebsiella pneumonia, as well as an E. coli. These were sensitive to Kef triazone. The nasal swab was also positive for Candida tropicalis that was sensitive to fluconazole. He was treated for all 3 infections with a course of Kef triazone and fluconazole, but there was no improvement in his cellulitis and clinical condition. Further of his blood workup, showed a limited immunoglobulin panel of an IgG and IgM, which showed low IgM. He had an ANA that was negative. His HbA1c was 6.1. He also had an HTLV IgG ELISA that was negative. An EBV viral load was also requested, but unfortunately, the sample was insufficient for this test. And I'll elaborate more on why this is an important test to do later. TB blood cultures were also sent that were negative. The patient then went on to have staging scans. And what the scans showed, the final report was that basically the disease he had was limited to the head. I'm now going to share some of the CT images here. And what you can see in this first image is basically the right buccal mass that is extending into and obliterating the sinusoidal spaces on the right. And on the next slide, what you can appreciate basically is this mass that is extending into his right orbit, and as well as obliterating his osteomeatal complex. Mr. KM went on to have a biopsy done of the lesion in his mouth. And what the histology showed, the initial provisional diagnosis was that of an anaplastic large cell lymphoma while awaiting further stains. On further staining, the biopsy showed a positive Epstein-Barr virus in situ hybridization, EBRISH. And with that result, the diagnosis of anaplastic large cell lymphoma was revised to that of an extranodal natural killer T-cell lymphoma. The biopsy was also sent for a polymerase chain reaction, PCR, for T-cell receptor gamma chain gene rearrangement, and that was negative for clonal T-cell rearrangement. The final histological diagnosis was that of extranodal natural killer T-cell lymphoma nasal subtype. As part of his workup and staging, the patient also had a bone marrow. And what the bone marrow aspirate showed is a prominent hemophagocytosis with no overt evidence of a lymphoid infiltrate. The bone marrow trephine also showed this hemophagocytosis, and it was basically assessed that the hemophagocytosis was basically contributing to the cytopenias that the patient had, as well as potentially other peripheral causes, such as sepsis, DIC. The trephine did not show any obvious foreign infiltrate. The PCR for T-cell rearrangement was also sent on the bone marrow, and this was negative. A TB blood culture was also done, and this was negative. The final assessment of the bone marrow examination was that of no evidence of bone marrow involvement by the natural killer T-cell lymphoma. I'm going to take this opportunity to just discuss briefly some of the presenting symptoms of peripheral T-cell lymphomas, because as you know, they are not the easiest diagnosis to be made. But if patients present basically with hemophagocytic syndrome, if they present with the pulmonary syndrome, if they present with the facial or sinus syndrome, or just systemic illness with atypical organ infiltration, you always need to bear the diagnosis of peripheral T-cell lymphoma at the back of your mind, as was the case in our patient with the hemophagocytic syndrome. Our patient went on to start chemotherapy. He was started on a SMILE chemotherapy protocol, and Sandwich radiotherapy was planned. Our patient unfortunately demised from bone sepsis. So not the best ending of our case, really. I'm going to now move on to the next part of my presentation, which is a background on extranodal natural killer T-cell lymphoma. So this slide is basically just reminding us of the hematopoietic process. Basically, we start off with a multipotent hematopoietic stem cell. This branches into a common myeloid progenitor, as well as a common lymphoid progenitor. The common lymphoid progenitor is the focus of our talk here. And basically, from that common lymphoid progenitor, you get your small lymphocyte that gives B lymphocytes and T lymphocytes. That same common lymphoid progenitor can also differentiate into natural killer cells. I'm going to take this opportunity to also just differentiate between natural killer cells and natural killer T cells. So natural killer cells are a type of cytotoxic lymphocyte, and they are part of the innate immune system. This is in contrast to the natural killer T cells that are a type of T lymphocyte that are part of both the innate and adaptive immune system. The T lymphocyte, as we all know, is basically part of the adaptive immune system. Just a bit of a history lesson as well. Natural killer T-cell lymphoma was first described by McBride in 1897. And it was basically this lymphoma that had a rapid destruction of the nose and face, basically the midline, with a clinical cause of a progressing necrotic granuloma. It was generally very aggressive and lethal. And at the time, terminology such as rhinitis gangrenosa progressiva, lethal midline granuloma were used to describe this lymphoma. Since the late 20th century, this disease had been coined then as a nasal T-cell lymphoma based on the finding that tumor cells had a T-cell phenotype. And it was subsequently then found that these cells also express the natural killer cell marker CD56, and then the term natural killer T-cell lymphoma was coined. In the current day, in the World Health Organization 5 of 2024, there is a section where they describe and discuss T-cell and natural killer cell lymphoid myeloproliferative neoplasms, and our focus here being basically the extranodal natural killer T-cell lymphoma. So what is extranodal natural killer T-cell lymphoma? It's basically a type of an aggressive non-Hodgkin lymphoma, and it originates basically from both natural killer cells in 85% of the cases, T cells in 15% of the cases, and it is one of the Epstein-Barr virus associated malignancies. We test for Epstein-Barr virus with the Epstein-Barr encoding region in situ hybridization, IBRISH. The most commonly involved areas by extranodal natural killer T-cell lymphoma is basically mucosa of the nasal tract and the surrounding areas, often leading to rapidly progressive destructive structures. Other systems can be involved, such as the digestive tract, pulmonary system, skeletal, dermatological, and reproductive system. There is a very significant geographic variability in extranodal natural killer T-cell lymphoma, with a higher prevalence in Eastern Asia and Latin America. And basically, there has globally been an improved overall survival in the past 2 decades of extranodal T-cell lymphoma, and this is due to improvements in both radiotherapy and chemotherapy. I'm now going to move on to the next part of our presentation, which is the exciting part really, and this is our study. And we'll start off with basically the rationale of our study. There's very limited data on extranodal T-cell lymphoma in South Africa. And additionally, there's even more limited data on the clinical pathological characteristics, the prognostication, the treatment, and the outcomes of this lymphoma. I'm now just going to share some of the data I found from Africa on extranodal T-cell lymphoma. And the first publication, as far as I could find anyway, was back in 2013, where the team at Medunsa, previously called Medunsa, now called Sefakomrati University, where Prof. Bida and his team basically described extranodal T-cell lymphoma using that term that I used earlier, this midline lethal granuloma. This was a case report. This is one of the pages in that case report sharing two images, as we can appreciate that necrotic midline granuloma with the CT showing how invasive that lesion is. I also went on to find this paper, which was basically part of the International National Hodgkin Lymphoma Classification Project that ran over 1985 to 1995. And Dr. Perna, who's presenting with me today, was part of that paper. Basically, they described non-Hodgkin lymphomas, both in the Johannesburg and Cape Town areas. In the paper, they quote a frequency of extranodal natural killer T-cell lymphoma of 0.4% of the non-Hodgkin lymphoma cases. This is a case report I wrote up with Dr. Philip and Prof. Patel. This was in 2022, and it was actually of the young man that I presented earlier. Basically with extranodal natural killer T-cell lymphoma. It's quite fascinating at the time to see the case. And if I remember correctly, in Prof. Patel's words, basically it was the first case that he was seeing in the Bahrain area in his time here. So as far as can be ascertained, our study is the largest cohort of extranodal killer T-cell lymphoma in Africa. Still sharing that literature that I found basically on this lymphoma in South Africa and Africa. There's a paper from back in 2017. This was published from Malawi, rather, where they described 3 cases of extranodal natural killer T-cell lymphoma at one of their teaching hospitals between 2013 and 2014. Another paper I found was a paper from Senegal that was published in 2018 by the Haematology department at one of the hospitals in Senegal. And they found 7 cases of extranodal natural killer T-cell lymphoma between 2011 and 2016. The last paper that I found on extranodal natural killer T-cell lymphoma from Africa and South Africa basically is a paper from Tunisia from 2019. And in this paper, they described 9 cases of extranodal natural killer T-cell lymphoma between the years 1997 and 2017. So basically, like Dr. Prasnath said, my study basically is a 10-year retrospective study, and we looked at the incidence and characteristics of extranodal natural killer T-cell lymphoma. My supervisors for the study were Professor Estelle Brer and Professor Vernon Lowe. The study basically included 3 centers. So Chris Hani Baragwanath, which is part of its university, Groote Hospital, which is part of the University of Cape Town, and Nkosi Albert Luthuli Central Hospital, which is part of University of KwaZulu-Natal. We're now going to just go over the inclusion criteria for the study. We basically included patients that had confirmed pathology report of extranodal killer T-cell lymphoma and were treated as extranodal killer T-cell lymphoma by the treating clinicians. The other inclusion criteria used was we looked at adult patients, and adult was defined basically by different ages based on the different hospital policies, with Chris Hanley using an age cutoff of 18, Fortescue using an age cutoff of 14, and Nkosi Albert Luthuli also using an age cutoff of 18. We included patients as part of the study, irrespective of the stage of the disease and the treatment they received, as well as irrespective of their HIV status. The exclusion criteria for the study, we excluded patients that were diagnosed with extranodal killer T-cell lymphoma, but for one reason or another, never made it to a clinical hematology center. So basically never really got treatment. We also excluded patients with CLL from our non-Hodgkin lymphoma cohort because of its unique clinical course as a non-Hodgkin lymphoma. Our findings, basically, in a nutshell, we found 12 cases over the 10-year period. And this is from the 3 centers. The one case being from Chris Hani Baragwana, where they had a total of 1,084 non-Hodgkin lymphoma cases. 4 cases were from Fortescue, where they had a total of 1,335 non-Hodgkin lymphoma cases. And the largest cohort was basically from Nkosi Albert Luthuli, 7 cases, and they had a cohort of 1,683 non-Hodgkin cases. So there seems to be something in the case of an air, essentially. This is a summary of our table 1, basically. It's a bit of a busy slide, but essentially what I would like to emphasize is the 12 patients that are, so the numbers 1 to 12 representing the patients, and the same numbering will follow in the subsequent tables. Of note, basically all patients were African Black. Only 3 patients in our cohort were HIV positive, and almost all patients had nasal involvement. There was only 1 patient with bone marrow involvement. Table 2 that I'd like to share is basically the immunohistochemistry and impression results of patients. And again, another busy slide, but as can be appreciated, basically there is a bit of heterogeneity in terms of which stains are done at different centers. But what you can appreciate is that almost all the cases were CD3 positive, almost all the cases were CD56 positive, and all the cases were Iperish positive. The last table, basically in our study, was that of prognostication, treatment, and survival duration of the patients. And again, here we appreciate quite a bit of heterogeneity in the treatment regimens that are used for extranodal natural killer T-cell lymphoma. What you can appreciate as well here is that only three of the patients are still alive. And a very important factor that I'll elaborate on later is basically how radiotherapy improves survival, basically in patients with extranodal natural killer T-cell lymphoma. I'm now going to hand over to Dr. Perna, who has already been introduced by Dr. Parasnath, who will go through the histological diagnosis of extranodal natural killer T-cell lymphoma. Over to you, Dr. Penner.
Thank you, Matlatsi. Matlatsi, can you see my arrow?
I am not seeing it. Maybe move it around a bit.
Can you advance onto the next slide, maybe, please?
Okay, sure.
Can you see the arrow now?
I could see an arrow just now, but now I don't.
I think perhaps
Okay.
try and move the arrow towards the top of the.
Oh,
There
there
we
it
go.
is. Yes, it's there.
Can you see here? Okay. All right. Thank you very much. So this is a biopsy taken from the patient at Baragwanath Hospital. It's a mucosal biopsy from the clinical photograph that was shown previously, and there is no residual remaining mucosa. It is all ulcerated and replaced by a fibrinopurulent exudate. If we could proceed to the next slide. This is taken at a different place. You can see skeletal muscle on the right-hand side here. There's a bit of mucosa down towards the bottom, and here on the left-hand side, and this extensive mucosal ulceration with a crushed cellular infiltrate in the submucosa. Next slide. Again, the fibrinopurulent exudate on the mucosal surface, and one gains an appreciation of a mononuclear infiltrate within the submucosa deep to the area of ulceration. Next slide, please. So this is a high power view of the infiltrate beneath the ulcerated surface. It needs to be said that there was no angio-invasion or angio-destruction by this tumor, and so that is a classical feature of this tumor. It was formerly called angiocentric T-cell lymphoma before it was called natural killer T-cell lymphoma. So that wasn't a feature in this particular case. But we can see many large tumor cells. The infiltrate is mitotically active. The tumor cells have a clear cytoplasm, which is characteristic of peripheral T-cell lymphomas in general. Next slide, please. There is abundant nuclear pleomorphism. One can see, again, mitotic activity here, any number of different shapes of nuclei, small, medium, and large cells, infiltrating between skeletal muscle fibers taken from the buccal area. Next slide, please. And the same field taken under oil. Mitotic figure and binuclear tumor cells, a very aggressive tumor with large number of pleomorphic cells, multilobated cells, and an aggressive looking lesion. Next slide, please. So the immunohistochemistry confirmed CD45 positivity, that's leukocyte common antigen, so it would stain any lymphoid cell positively. The CD56 was useful. So CD56 is also known as a neural cellular adhesion molecule. It isn't a lineage defining marker, and it is seen variably expressed in other kinds of peripheral T-cell lymphomas. But in this area, it becomes diagnostically significant for an NK T-cell lymphoma. On the right-hand side, you can see that the tumor cells, some of them express CD3. So the negatively staining ones may very well be natural killer cells that do not express CD3, but will express cytotoxic markers, which were not done in this case. Next slide, please. And the diagnosis is really clinched by this EBA, Epstein-Barr virus small RNA in situ hybridization stain, which stains the nuclei of tumor cells this dark blue-black color. So it really is a constellation of features. The clinical presentation the high-grade cytomorphology, the lack of CD3 signaling in all tumor cells, opening the gateway for a natural killer cell phenotype, which could have been marked with granzyme B, perforin, TIA1, for example, but were not done. And then the EBO positivity confirming the diagnosis. So just to mention that EBO, in situ hybridization studies, are positive in a number of non-Hodgkin lymphomas and in Hodgkin lymphomas. So, for example, in nodular sclerosing Hodgkin lymphoma, EBO positivity is seen between 10 and 25% of cases in Wheat-Sternberg cells. In mixed cellularity Hodgkin lymphoma, that number is much higher. It's seen in about 75% of Wheat-Sternberg cells. But these tumor cells do not resemble Wheat-Sternberg cells, and they would not be CD56 positive, and they would not be expressing CD3. There are any number of B-cell non-Hodgkin lymphomas that stand positively with EBO. The classic one would be plasmablastic lymphoma. There are a number of diffuse large B-cell lymphomas that express EBV. Burkitt lymphoma is also another classical example that's EBV positive. So this is a constellation of histological and immunophenotypic features that allow for a confident definitive diagnosis. Next slide, please. So the synonyms for extranodal NKT cell lymphoma of nasal type were in the past angiocentric T-cell lymphoma, polymorphic reticulosis, and lethal midline granuloma. And all of these terms are now considered to be obsolete, and as has already been shown, the tumor consists of either natural killer cells or T cells. Next slide. So just to quickly recap what those are, although that has been done already, natural killer cells form part of the innate immune response system, and they are rapid responders that mount an immune response within days. They kill virally infected cells and tumor cells without prior sensitization. And the recognition that these cells are abnormal is primarily due to the loss of MHC expression. The cells release cytotoxic granules that invoke apoptosis, and they also release cytokines such as interferon gamma and tumor necrosis factor, which activate other immune cells to mount an immune response. Whereas T cells are part of the adaptive immune response, and they respond to antigen-presenting cells, and they respond within about a week following antigenic exposure. And they can be divided up into either cytotoxic T cells, which are CD8 expressing, and they release perforin and granzyme B and induce apoptosis, or T helper cells, which are CD4 expressing, that release cytokines that speak to B lymphocytes to mount an immune response. Next slide, please. So the immunophenotype for NKT cell lymphomas is variable depending on whether or not it's a cytotoxic T cell or a natural killer cell. But usually what is positive are CD2, which is it's T cell marker, CD56, CD45RO, and CD43 are also second and third line T cell markers, and CD57 is often positive. And then the natural killer cells will also express granzyme B, perforin, and TIA1. Negative stains are usually CD3. If it is a cytotoxic T lymphocyte, it would be CD3 negative. CD4 and 8 are often dually not expressed, and CD57 and LMP1 are often not expressed as well. Next slide, please. A few words about EBO in situ hybridization. There are two main types, EBO 1 and 2. They are highly stable, and they indicate a dormant host infection that disrupts host immunity and allows for tumor cells to evade immune detection. So EBOs promote cell survival and proliferation. They block apoptosis, and they upregulate the production of interleukins 9 and 10, so promoting cell survival. Next slide, please. The genetic profile of NK T cell lymphomas is extensive, as it is in most of the lymphomas. And I think we're still at a stage where we are discovering common trends amongst tumors. And at the moment, everything is included in the WHO. T cell clonality is only expressed in about 10 to 40% of cases, and those are then of the actual T cells, probably cytotoxic T cells, whereas gene expression, whereas T cell clonality will not be expressed in natural killer cells. They will be in the germline state. And that's a diagnostic pitfall, just to pick up a polyclonal T cell gene rearrangement product does not indicate that it's not neoplastic. There are no specific chromosomal translocations, a variety of cytogenetic abnormalities, and genetic aberrations. Next slide, please.
That's
And that's
the last of your slides, Dr. Penna.
Thank you very much.
Thanks, Dr. Penna. Okay, so we are basically now still on discussing the findings of our study, and the next section that I'll be discussing of our findings is the epidemiology and demographics. Just to recap that table again that I went through earlier. So in terms of the epidemiology and demographics, as stated in the introduction, the exonodal natural killer T-cell lymphoma is more common in East Asia and Latin America, where 5 to 15% of the lymphomas have been reported to be exonodal natural killer T-cell lymphoma. The incidence in European countries and the United States is low, and they account for 0.2 to 0.4 of non-Hodgkin lymphoma cases. And one study from the studies I shared earlier reported an incidence of 0.78% of non-Hodgkin lymphomas being NK external natural killer T-cell lymphoma, and this was the study in Tunisia. Our study basically showed very low prevalence of external natural killer T cells, and they made up basically 0.003 of the non-Hodgkin lymphoma cases. So just a very big contrast between East Asia and Latin America and the rest of the world. There's a study that was done in the United States of a racially diverse cohort, and they looked at the racial / ethnicity differences of exonodal killer T-cell lymphoma. They included patients that were African American, Hispanic whites, Asians / Pacific inlanders, and non-Hispanic whites. And what they found is that Asians and Pacific inlanders, as well as Hispanic whites, had a higher prevalence of exonodal natural killer T-cell lymphoma than non-Hispanic whites and African Americans. This contrasts basically our study, like I said, where we have a very low prevalence of external natural killer T cell, despite the racial diversity of people seeking healthcare in our healthcare system. The median age of presentation globally is about 57 and 59 years in East Asia and Latin America, respectively, while the median age of presentation in our cohort was 36 years of age. So there's obviously a question of why the higher prevalence of the exonodal natural killer T cell in East Asia and Latin America. And what they have studied basically is genes that could be contributing to exonodal natural killer T cell. there's a study that was done in East Asia. Unfortunately, the study did not include patients from Africa, Europe, and the United States, but it is the largest cohort to look at the genetic makeup of patients with extranodal killer T-cell lymphoma. And what they found is that HLA-DPB1, IL-18, RAP, and HLA-DRB1 associated with an increased risk of extranodal natural killer T-cell lymphoma. There is a study that was done basically by Ko, MJ, et al. And what they looked at is comparing outcomes of extranodal natural killer T-cell lymphoma in patients that are HIV positive and those that are negative. And what they showed is that overall survival was better in patients that do not have HIV compared to those that do have HIV. What they also went on to show is that patients with higher CD4 counts and lower viral loads had a better overall survival. In our cohort, we had 3 patients that were HIV positive, and there was 1 female patient who was HIV positive and virologically suppressed, and she did very well and achieved a CR. This basically supports the study by Ko, MJ, et al. This table is just reminding us again of the immunohistochemistry and average results of our cohort. So Dr. Penner extensively discussed the diagnosis of extranodal natural killer T-cell, but this is the WHO basically diagnostic criteria of extranodal killer T-cell lymphoma, with essential criteria being infiltration of extranodal tissue by lymphoma cells with variable morphology, like Dr. Penner said. There's NK or cytotoxic T-cell phenotype, and the majority of the cells are positive for EBA. A desirable criteria is angiocentric growth and necrosis. The slide just recapping the prognosis, treatment, and survival of our cohort. As I discussed, basically the staging and prognostication of extranodal natural killer T-cell lymphoma. So extranodal natural killer T-cell is most commonly staged using the Ann Arbor system. However, there are multiple other systems that have been suggested and are being used. The first is the TNM staging, which basically makes sense really, because this particular tumor doesn't behave like a classic lymphoma, so to speak, with lymph node involvement. So it makes sense why TNM staging would be desirable to use. The other staging system that's used is called the Korea system. Basically classifies systems into upper airway digestive tract disease, as well as non-upper airway digestive tract disease. One more system that is used is called the CA system, that was established based on anatomic factors, and it can efficiently classify patients into different stages. This table just summarizes really the advantages and disadvantages of the various staging systems. I will not extensively go through the table, but essentially the Ann Arbor staging being popular and easy to use system, and it can very easily basically differentiate between the different stages of extranodal natural killer T-cell lymphoma. In terms of prognostication, there is the PINK and PINK-E score models that are used to prognosticate patients with extranodal natural killer T-cell lymphoma. The parameters of the score basically being an age greater than 60, stage 3 or 4 disease, non-nasal primary localization, distant lymph node mets, and detectable plasma eDNA. And patients are prognosticated into either low, intermediate, or high risk based on the amount of points they get. And a higher pink score basically correlates to poorer survival. However, in our cohort, we did not find this correlation because 2 of our patients had high scores of 2, but these are patients that actually ended up achieving a complete remission. Another very important prognostic marker of extranodal natural killer T-cell lymphoma is Epstein-Barr virus plasmid DNA. And this is both used for prognostication and response to treatment. So our table 3 again of our findings and going through the treatment and outcomes of extranodal T-cell lymphoma. Globally, like I said, there's improved overall survival over the last 2 decades. And this has been due to advances in radiotherapy, as well as introduction of asparaginase and PD-1 and PDL1 ligand immunotherapy. Extranodal natural killer T-cell lymphoma has been noted to be very selectively sensitive to asparaginase. So it is suggested that treatment protocols be those that contain asparaginase, like that PD-1 and PDL1 inhibitors are also found to be active in extranodal natural killer T-cell lymphoma. What has been found also is that extranodal natural killer T-cell lymphoma is very highly radiosensitive, and it's also been established that higher doses of radiotherapy than was previously used for extranodal natural killer T-cell lymphoma are necessary to improve long-term survival, and we are talking doses of about 50 gray being necessary to achieve long-term survival. Radiotherapy has been it's being utilized as either sandwich therapy or sequential therapy. And sandwich basically means in between your chemotherapy cycles, you give radiotherapy, and sequential being complete your chemo, and then at the end you give your radiotherapy. Extranodal natural killer T-cell has interestingly been found to be unusually resistant to anthracycline-based chemotherapy, as well as methotrexate and cytarabine. This slide, I'm not sure even projects nicely on your side, but it's a very long list of chemo protocols that can be used in natural killer T-cell lymphoma. And like I said, with those that contain asparaginase being the suggested and preferred protocols. This table that I'll also not extensively go through goes through some of the chemo regimens that contain asparaginase, and some patients also getting radiotherapy and their overall survival, basically. These are examples of protocols that I found that basically describe the sequential and sandwich chemotherapy and radiotherapy that I mentioned. For example, SMILE being given weeks 1 and 2, and then weeks 3 to 5, you give radiotherapy. This is sequential chemotherapy. And then sandwich chemotherapy, for example, Gelox, where weeks 1 and 2, you give chemotherapy. In between, you give the radiotherapy, and then you resume your chemotherapy after the radiotherapy. There's basically a consensus that for early stage disease, so stages 1 and 2, radiotherapy alone is the preferred treatment algorithm, while patients with stage 3 and stage 4 disease, you want to use asparaginase-containing chemotherapy with radiotherapy. The role of hematopoietic stem cell transplant in extranodal natural killer T-cell lymphoma is controversial. This being because both auto and allogeneic hematopoietic stem cell transplant have been evaluated in extranodal natural killer T-cell lymphoma and have both been found to be no better than asparaginase-based chemotherapy alone. Patients in our cohort from the tables could be seen had very dismal outcomes with a median survival of about 5 months. Also of note is that even though the literature suggests that extranodal natural killer T-cell lymphoma is resistant to anthracycline-based chemotherapy, 2 of our patients actually got CHOP chemotherapy and achieved CR with that chemo regimen. It is also important to note that survival was poor in patients who did not achieve. Our study had some limitations. The first being that our cohort was small, despite the study covering a 10-year period. So very limited conclusions can be made from our study. Other limitations basically was the heterogeneity in the immunohistochemistry that's done by different centers. They're also very challenging to compare cases. And the last limitation that I'd like to mention is that our healthcare system has a lot of hospitals that are more remote, and samples sometimes are collected there and have to be transported to the larger academic hospitals. Prolonged formalin fixation due to extended travel times from peripheral to central laboratories can affect results, and this can be contributing to the low case numbers that we have. In conclusion, extranodal natural killer T-cell lymphoma is extremely low in the South African patient population. The clinical pathological features of our cohort were comparable with global data. Outcomes were very dismal. This is in contrast to the improved survival globally. And we are suggesting basically a better collaboration between smaller hospitals and larger centers to diagnose patients earlier and refer them for treatment so that we can treat the disease early, and hopefully we can reach these better outcomes that have been seen globally. These are my references. Share if you'd like. And in terms of acknowledgements, I'd like to thank my supervisors, Prof. Ferrer, who I'm glad is in the audience, and Prof. Lowe. I'd also like to thank the research coordinators at the UCT Clinical Haematology Unit, with a special thanks to Jenna Ostazen and Karen Brown. Amazing 2 ladies. I'd also like to thank the Fogarty Grant and Prof. Edward Murphy, who allowed me to attend the manuscript writing course. And would like to thank the administrative staff at Chris Honey, Fortescue, and Jose Alberto Tuli for helping us collect data. And lastly, I would like to thank Blood SA for the opportunity to present the data today. And just this last slide, this is a picture I took of the sunset at Chris Honey Barra, one of my late days. Yeah, just at the back of Barra. Thank you so much.
Thank you, Mashlatsi and Dr. Perna. That was really well presented and really interesting data. You know, the one thing that I, from our points of view from in KZN, that actually stood out. So if you work in KZN, you'll understand that we do have a I wouldn't say a significant number of Indian people that access the public healthcare system, but the KZN population is about 9.3% Indian. And interestingly, none of the patients actually were Indian or were of African Black origin, and none were white as well in our setting. So it seems to affect of the African population in our setting. And the other thing that stood out to me in our patients was that many of them actually were HIV negative. In fact, currently, well, this year we diagnosed two patients. Uh, both were under our care. One actually passed away last week. And I think for me, the challenge comes is those patients that have the extensive, breakdown and erosion into the sinuses, etc. That there's an increased risk for infection. And the patient that passed away last week actually died from infection, and the previous patients as well. From what I remember, is that the infection is what actually kills them. So those are some from my perspective that I think are actually a problem. I think that the other thing is that it's important actually to highlight these cases such that doctors in the peripheral hospitals actually up these cases early and refer them for a biopsy and treatment, because the later we get them, the poorer is the outcomes. And yeah, so that was just a little bit I would like to actually discuss from our point of view. Um, I don't see any questions in the chat, Mishlatsi. I don't know if Estelle wants to actually give her comment. Wait, there's something here. There's a question that's best been posted. Oh, Jasmine says, well done. A beautiful session of clinical and histological imagery. Is EBV PCR on frozen tissue or histological samples available in routine practice, given that it's the most sensitive modality compared with even situ hybridization and EBV serology? I don't know if Dr. Parna wants to answer that.
Thank you. Thank you, Dr. Parasnath. So, no, answer in brief, no. We don't do EBV PCR from histology side. I'm not sure about infectious diseases, whether or not microbiology is doing it, but certainly from tissue diagnosis, we don't use it. Thanks.
Yeah, I just want to agree that
Dr. Parna,
it's very well done.
yeah,
Yeah,
sorry,
sorry.
Estelle, go ahead.
Do you have a question?
No, you go ahead, Estelle. Thank you.
You wanted to ask Dr. Perner a question. Quickly ask that first.
Oh, yeah, I just wanted to inquire about the T cell receptor gene rearrangement. Is it useful if it's an obvious, I mean, is it a test that we should be doing or shouldn't? Because I guess if it's an NKT, it's obvious, then it's a useful test. But if you are um, thinking perhaps when you're working the case up, is it a peripheral T cell, then the T cell receptor gene rearrange? I'm just wondering, what is the utility? Is it really worth us doing the test?
I think it is worth doing, because I think that in the back, it's a supportive of an NKT cell lymphoma in those cases where it's the natural killer cell, and that's the majority of cases, is the cell of origin, because they will be in a germline state, and so you won't get a clonal reaction product. As is always the case in our environment here in South Africa, we cut our coat according to the cloth. And so there are many times where we don't do an extended profile that includes a full T cell workup, and we don't do the natural killer cell markers, the granzyme B perforin TIA1. And so I think whatever is being used within anatomical pathology laboratories in the country that's easily accessible and that's part of your routine workup, you do as best you can. Yeah, thanks.
Thank you. Estelle.
Yeah, I just want to come back to Jasmine's question. I mean, I think Mashlatse will be the one that can help me right here, and you perhaps, but I would have thought EBV viral load in the plasma would be, or serum, whatever. So viral load, not serology, but viral load would be what I would have thought to follow it with. Not that I've even been given the chance to really follow them up. At our unit, as you can see, there's been very few. So I'm not aware that you can follow them with PCR on the tissue because you're not going to biopsy them again.
Mm.
You're just going to biopsy them once. And I must say that even in Europe, these cases were uniformly fatal where I used to work. So I do agree with Jacques, as I also wrote there, that I do think if there is a better outcome nowadays, it's probably because of really, really early stages. And I know Mashlatsi didn't think they were also late stage, isn't it not, Mashlatsi? You thought some of them were earlier, isn't it? But I was interested, you spoke of the pink score that was only was high in 2 of the 3 people who went into CR. What about the other, what is it, about 8 people? What was their pink score? Was that also high or not?
Sure.
What is that?
Just to answer the first question, Professor Bear. So what I saw in the literature is that they use the EBV viral load
Yes,
trend. So basically the
yes,
diagnosis viral load, and then we follow the trend. And in
exactly.
some papers, basically, patients that go into remission, the viral loads were used as a marker to monitor for remission. And then the second question, Professor Bear, yeah, most of our patients had low pinky scores. So yeah, that's.
I do wonder if we haven't missed some staging. I think that's sometimes, it's quite tricky, I think, because I think they were probably higher than we think. That's just my opinion. But all I'm saying is I've never seen any of them in my career, even in Europe, get into remission. And I do believe that the radiotherapy, early radiotherapy, probably with early diagnosis, that type of stuff, I think the early recognition is probably much better in many places in the world, and that may help. And that people get
Yeah.
biopsies and so on. So the one thing that I just think that we are going to work on with our team on this paper is I think we've got one center where it's a clinico-pathological database and 2 centers where it's more a pathological database. Is that correct, Mashlatse?
Yes, Professor Bear.
And it would probably be wonderful, it would have been amazing if we could bring it to all 3 centers so basically our center will have to become a pathological database. And then the question would then be, just for interest's sake, if it can be verified, those cases that were never seen could then also be included as those cases who didn't make it to therapy. But I really, from my side, just as a last word, and I'd also like to know what Prof. Lowe thinks or whoever else wants to comment, but we are just very, very happy that we could work with the 2 other, universities in 2 major provinces. It gives us an incidence of a very rare disease. We agree that it's rare, but it does give us some data that is quite interesting. And I agree with Charlene. The racial thing is strange and new. That is really something that is not what would have been expected. You would have expected for example, in KZN, you would have expected more Asian patients, if you go by the world literature. So it is different than what we would have thought it to be, and that is really remarkable. So it was a piece of work that I think we all derived great, what shall I say, professional satisfaction, even if not for the patients. And Mashlatse, you are an amazing ace in research. You are just an ace. You are brilliant in research. Just want to absolutely give you that respect from us.
Yeah. That's well done, Mishlatzi. I agree with Estelle. I see that Caroline Stain is from the Free State, and she says, we recently had a Caucasian patient with this diagnosis, and she thanks you for your interesting data. Jacques says a challenge with this disease is rarity, which contributes to delays in diagnosis is highlighted. Outcomes for early stage is supposed to be very good, but all our patients, which are very few, present with advanced disease because one treats it so infrequently. It's a bit of a scramble to refresh one's knowledge when you see a patient. So Jacques, I'd like to make a comment about that. So I'm by no means an expert, but I think with the patients, we started using Smile the time I joined as a fellow, and I must say that it is it is not a difficult protocol to use. However, I think an important thing to watch out for is the infection because that's what kills the patients. Usually they tolerate it quite well, and even those that have quite destructive lesions. So it's not a difficult protocol to use per se, but yeah, I think it's the infections that's the problem. Um, and then Raquel Viana says we do EBV PCR from histoblocks at Lancet. Then Estelle did speak about Herbert.
And
She said, yeah, I agree.
Lee,
Yeah, yeah,
can we just
yes.
ask Raquel what she means? Because that was why I asked, is I only know viral load when you follow them clinically for the EBV, but
Okay.
Raquel is very she's very highly qualified in this area. Why would you do the EBV PCR on the histoblock? And that's probably where Yasmin also has her idea from. So can you guys explain to us? Don't know
Hi,
if that's
Estelle, this is Raquel.
Raquel.
Hi,
Can you hear
Raquel.
me? Hi.
Yes.
So I
Yes.
was just talking to our ability to do it. It is something that we offer, and it's something that we've managed to get working well on our histoblock. So we do quite a few of our infectious targets. We can do off histo specimens. So it's not per se that we're doing them specifically for this diagnosis and this entity. It's just an ability that we have to be able to do it.
Okay, great. So you would still do the EBA stain as a first sort of a first step, but you can do
Yes. And we still do the monitoring of plasma for the EBV viral load testing. It's just that if there is a query on a block and they want to know if there's EBV, we are able to test for it. We don't give a viral load off the block. We would just give a qualitative results. So yes or no, it's present.
Okay. Okay. Great.
Sorry, Estelle, I see Vernon's on the call after a long time. I don't know if Vernon, do you want to say anything?
Hi, Charlene. Hi, everybody. Thank you
Hi.
for the opportunity to comment. First, great work, Machlatsi. Well done. And I think these projects take quite a bit of logistical and administrative effort to run it through 3 different ethics committees and coordinating different centers. And I also have to say you've done very well and congratulations on the work. And at the same time, I think this should serve as an encouragement to other registrars and MMeds to consider looking at rare diseases in our environment, because many of the rare diseases remain very poorly described in our region. So there are great opportunities. I think this is a lovely model, this particular study, for others to do. And I really hope that through Blood SA and other ventures, we can do more of these collaborative projects together. I see Jacques has already indicated his keenness to be part of it, and I'm sure, and I hope other people will say the same. But we've got the opportunities, we've got the great people, we've got private and public sector that can work together. It doesn't have to be just one side. And we can really provide make great contributions to the world literature, because Africa has got something different to give that the rest of the world can learn from. And all of us, of course, and hopefully help our own patients as well. So no, well done. Very happy. And I look forward to seeing many more such studies and presented here, deep dive and collaborations.
Thank you, Vernon. It's nice to see you after a long time. Is there anybody else that wants to comment? I don't know if Fatima Faisal's on the line still. I just want to know what has been her experience at Tygerberg in the time that she's been there.
Yeah, Charlene. I
Hi.
think when Masati approached Fatima Bassa for this study, we hadn't had any patients that we could think of.
Okay.
I think, like Jacques said, they're a little bit, few and far between. But in the past couple of years, we've had 2 patients that I can recall. And one was an elderly female who actually presented to the ICU initially, and we were referred to see her there. She was unwell. She got a bit of debulking chemo when we actually had to palliate her. She was extremely unwell. It was a delayed diagnosis, and she was quite wasted and not fit for chemotherapy. But the one patient we have now is in his 30s, and we've actually decided to give him the LVP regimen, which is LASPA based, but I think a little less toxic than SMILE. It's usually 3 cycles and then also sandwich radiotherapy. So we sort of now at the radiotherapy stage. He had a CR after 3 cycles of LVP. So we hope we can maintain the remission in him. And it was reasonably well tolerated, very little toxicity. He lives far from the hospital and he was able to go home. It's a 5-day regimen, so he stayed for the 5 days and was able to go home after that.
Thank you, Fatima, for that. The other thing that I meant to mention about our case is that you would actually need to have a multidisciplinary team when these patients do actually make it through and survive. To my memory, there was one patient that had a defect in his heart palate, which needed plastic surgery to repair that. He's still one of the survivors, but I actually need to follow up and see whether it was actually closed. But to remember that you might have to get maxillofacial, in fact, plastic surgery involved because this becomes a problem even when they do survive for food and getting lodged in the defect. So that's another aspect of the patient's and not to forget the psychosocial aspects of it, because the disease is actually quite destructive, and um, the facial features are distorted significantly. So that's just another aspect that we also need to consider with our patients that do survive, that probably those things will impact them long term. So I don't see any more questions. There's one last comment here from Jacques. Would be great if all units can start using the Hopper registry. That way we can routinely collect robust clinical and outcome data. And Prof. Lowe says, remind of tomorrow's Waldenstrom support group meeting, and the details is on the SACHES web WhatsApp group. So please, it's also another rare condition, which would be, so it's good if you could all attend that. Yeah, so with that being said, if there's no other questions or comments, I want to thank Mashlatsi for sharing his study with us. I think it was wonderful, Mashlatsi, and I really enjoyed working with you on this. And Dr. Panna as well, thank you for sharing your knowledge and sharing the pictures with us, because those of us that have a pathology background, we like looking at these pictures, and I really appreciate your time and sharing your knowledge with us. And to everybody that contributed, Prof. Lowe, Prof. Verberg, appreciate you being here, and Fatima as well, Jacques online. Really do appreciate your contributions. And to everybody that attended this afternoon session, I'd like to thank you all, and we see you next week. I'm not certain what next week's topic is, though. So we'll see you next week. And thank you to the Blood SA team for putting together this meeting. And please do not forget to do the survey at the end. So good evening, everyone.
Thank you, Charlene. From all of us, thank you to you.
Oh, it's a
Thanks.
pleasure.
Thanks, Charlene.
Take care. Take care, everyone.
Good afternoon, everyone.
Thank you. Bye-bye.
Thank you.
Bye.
Thank you.